Thank you, everyone, for joining us for this session. We're talking about methadone in the time of fentanyl, and we'll be focusing on new approaches to dosing and titration of methadone, to trying to expand beyond thinking about just the doses of methadone in terms of encouraging people to engage in treatment, and some of the recent outcomes in terms of research around carries and pandemics. So, although, there we go. I will introduce myself briefly and let Andrew introduce himself. I'm a family physician and addictions physician. I've worked in community settings, and I'm now working at Women's College, which some would consider an academic setting and sort of a different perspective. And I also work with Medify in the role of medical educator, which is part of developing guidelines, educational programs, and a whole host of other things. So that's how I come to this work, and I receive salary support for those roles. Andrew, would you introduce yourself?
Absolutely. Good morning, everybody. My name is Andrew McLeod. So I'm an individual who, for much of my life, battled with addiction, specifically with opiate use disorder, among a few other addictions, and was in receipt of methadone and Suboxone and other OAT during that time. I come with some lived experience to bring, I guess, another side of the equation. That's to say, from a patient side, what that looks like, and look to bring some experience in regards to my lived experience with harm reduction, maybe looking at some of the impacts that I experienced as an individual receiving OAT. I look forward to being able to bring whatever I can to the presentation. Thanks so much. I do receive honorary from U of T, Medify, and CAMH for presentations. Thanks so much.
Thanks. So I mentioned I received salary support through Medify from the Ministry of Health, research support from CIHR and CCSA, have done some other speaking, and I guess my main sort of conflict to declare is that I'm a co-author of the Medify guideline on methadone treatment for people who use fentanyl. I'm identifying that, and I'm happy to discuss it and open to questions and critique on the guideline. And I will be discussing off-label use of slow-release oral morphine. So as I mentioned, I think, we'd like to use this as an opportunity, especially hearing from Andrew about the impact of traditional approaches to MMT on people who actually use OAT. And we'd like to describe the guidelines suggested approaches to methadone titration that can support more effective achievement of therapeutic levels, other strategies that may help to encourage people to remain in care, and then finally consider some of the emerging evidence on the safety and impact of take-home doses from pandemic-related research. And I'll just mention again that I put links to the methadone guideline and to the JAMA article about carries in the chat. So as I was thinking about this presentation, I was really thinking about the intersection of these three huge issues with respect to where we have been, where we are, and where we may be going in terms of care for people who use substances and people who use opioids particularly. And, certainly overlying all of this is the devastation being caused by the poison drug supply, fentanyl and the fentanyl analogs, and now the mixes of everything else within the fentanyl analogs that are causing such devastating overdose-related deaths, both among people who have opioid use disorder and those who wouldn't meet criteria for opioid use disorder, but might be using more episodically. And that crisis was what prompted a small group of us to start thinking about the methadone guidelines that we were working with and how those could potentially be failing people using fentanyl. And then sort of layered on that, as our work was going on, the CPSO rescinded the MMT guidelines. And I think probably most of us, trained and practiced under those guidelines, and the sense that they were, really prescribed. They were the Bible, and along with the guidelines went the expectation of your practice being reviewed every 1, 3, or 5 years and being noted for any deviations from those guidelines. And so I think they created a very restrictive environment under which we practiced. I think some of us also then leaned on those guidelines to avoid potentially, being more patient-centered or making more flexible adaptations. It's sometimes easier to say, well, that I can't because that's what the guidelines say. I think underlying some of that also, if we really look at it, maybe some of our own stigma and judgment towards people who use opioids. But that's probably another entire talk. And then, of course, as we went along with this work has come the pandemic, which we continue to be in, but prompted vast changes, even if temporary, in terms of prescribing strategies. And I really believe that we've learned quite a bit on many fronts, but specifically with respect to some of the flexibility that was demonstrated in ways that we can take that forward. And of course, layered underneath all of that are the systems that we operate in, our medical models, our payment models, the siloing of care, stigma, and many others. Andrew, I wonder if you want to comment.
Yeah, I'm looking at, and I'm reflecting back to my time when I was in receipt of MMT, and you touched on it, the rigidity of the program that was there and the rules that were in place that would require an individual to be at their appointment on a particular day at a particular time, regardless of what's going on in their life. And really what we're looking at is trying to mitigate death for individuals who suffer from opiate use disorder, and that we're trying to best support a patient while maintaining certain guidelines that exist. Is it absolutely necessary that we have an in-person appointment so that a patient can come in and do a urine screen? Is it absolutely necessary that I see you once a week or once every 2 weeks, or would a telephone appointment be something that's available? Or as a result of the pandemic, the emergence of a lot of telemedical type appointments going on. I mean, the poison drug supply is something that's people are dying on a daily basis. I do a lot of work within the recovery community, and I see this. And these aren't folks that are intentionally going out to overdose. Somebody who's on a regular basis using 2 to 3 points of fentanyl on a daily basis goes out and uses a half a point and dies. The guidelines that were there in the past absolutely were a little too rigid. And I recall many opportunities when I was in receipt of this and had to go to a funeral and wasn't able to get to an appointment and ended up losing, I wasn't able to get a carry for a funeral that was out of town. Ended up missing that appointment and therefore was left without methadone for days. We've really got to take a look at what is the flexibility that's available. And as a result of the pandemic, we've been able to see the benefits of being able to do this as a result of changing the way in which methadone is prescribed and dispensed. Thanks.
Thank you. So I thought that we would just frame this by starting with some cases that would be pretty familiar. Imagine Tammy, who's a 36-year-old new to you, who's injecting 2 to 4 points of fentanyl a day. She doesn't want to start on buprenorphine, even though, CRISM guidelines say that should be our first line. We recognize that there's a very important, role for starting methadone in people who've had experience and some success with it or who prefer it. And her UDS is positive for fentanyl as expected, but also coke, benzos, and amphetamines. And so the question is, what would be a reasonable starting dose for her? And I would suggest that under the previous guidelines, again, we know that those don't exist formally anymore, but they informed so much of our thinking. I think that many people would have said, well, there's fentanyl, that's high risk. There's benzos, that's really high risk. We've got to start cautiously and go slowly, right? Maybe 25 milligrams, maybe 20 or 25, because I'm worried about those benzos. Andrew?
And here's the thing, having been somebody who is using in excess of 2 to 4 points of fentanyl a day, what limited me in terms of my desire to come to the program and get started was knowing from my history that it was going to take me, a month, if not more, to get to a dose that was going to mitigate that withdrawal. And coming in, a 20 milligram dose is almost at the point where I would say to myself, what's the point? I mean, what's the point in coming in? And it's going to take me better part of 4 to 6 weeks to get to a dose that's going to allow me to live without the crippling effects of withdrawal. So a 20 milligram starting dose is absolutely not realistic for somebody who's using 2 to 4 points of fentanyl a day. And I think that a lot of those guidelines were built around when people were using Percocet and Oxy and other, prescription opiates. But here we are now with incredibly powerful street level fentanyl and carfentanil, where the goal should really be to get somebody to a dose that's going to allow them to not be on a daily basis out there seeking additional opiates, and knowing that that's going to happen over a period of time. But our old guidelines don't apply to this new drug supply that's out there. And I mean, the new guidelines, we need to get people to a dose as quickly as possible that's going to allow them to stabilize. And a starting dose of, I would say, a minimum of 30, and looking at the safest way that we can move somebody up to a dose that's realistic for them, while ensuring safety for the individual and for the community.
I just want to say that if you want to put comments or questions in the chat for generally or particularly for Andrew, please go ahead and do so. So case number 2 would be Roger, who most recently has been having a hard time getting to regular care because he has unstable housing. He's using a lot more fentanyl than Tammy, about 1 gram a day injecting. He's made it up to 60 milligrams, and he's been at 60 milligrams for 3 days, but then missed 3 days. And so he came in, but then he left again before you actually get to see him. And, what do you do in this situation? And I think that too often in the past, if a patient wasn't seen after 3 missed doses, they got no prescription until they came back to clinic again on a day that a physician was there who could see them, left a urine drug screen, was restarted all over again. And that obviously creates a huge challenge and dilemma each time someone's dose gets canceled.
Jennifer, I'm looking at this case, should maybe say case 2, Andrew, because I was Roger for a period of time. And here's the thing, we're not looking at somebody who's fallen off the radar for 2 months. We're talking about 3 missed doses. And having contact with Roger to say what's going on here. And by the way, like on a 3rd missed dose, there's absolutely, I would say, very little impact from a safety perspective to simply dosing him at his current dose, and making arrangements that, listen, can we have a telephone appointment? Can we set up an appointment for you? What works for you? What's going on in your life right now? Why did you miss your appointment? And a lot of this brings us back to patient-centered care. Do I know what's going on with my patients? Are they comfortable talking to me and telling me what's going on? For a good number of years, I struggled with the ability to be able to maintain gainful employment because I was, as people often, refer to this, I was handcuffed to this program. And it's not that I see it that way, but more along the lines of, if the program is so rigid that it's preventing somebody from enjoying any type of quality of life, we really need to take a look at that. So, I mean, here's somebody who's missed 3 doses. This can be resolved really quickly by a phone call, by dosing him at his pharmacy for a few days until you're able to arrange an appointment where he can come in. I mean, and I've been this guy who's gone, you know what? I've missed 3 doses and they're not going to work with me. You know what? The heck with it. I'm just going to use until next Wednesday or next Thursday when I can come in for an appointment. The sad reality is that for a lot of Rogers or Andrews is when I go out and decide to pick up some drugs so that I can just not live in that crippling withdrawal, is that a lot of those folks don't come back.
Yeah. So case 3 might be Andrew.
I think all 3 of them were.
So, you know, and really just to highlight some of the issues around carries, right? So this is an individual who's had 3 carries, never gotten to full carries because every so often his urine screens would show cocaine, even though he wasn't using opioids on a regular basis. But when he missed a pickup because he was out of town for work, couldn't get carries, pharmacies closed Sundays, he's in withdrawal, he's used, he comes back in, you know, maybe on a Monday morning, but now his urine shows fentanyl as well as coke and maybe benzos because that's what's in all of the fentanyl that's around. And he's, you know, facing a scenario of how is he going to continue to work? And I would suggest, I don't know if it needs a lot more elaboration, that, you know, many of us in the past would have said, oh, you know, there's opioids, we've got to remove a carry again, rather than necessarily giving someone, you know, sort of the benefit of, you know, this was a really unfortunate set of circumstances. This was a slip. This is someone who's stable and for whom carries are really critical to being able to work. And work is really critical to being able to maintain everything else in people's lives often, right? Yeah.
You know, it makes me think about this whole, and there's some discussion to be had surrounding carries. You know, what is the purpose of this? I lived in the era of methadone, in which it was very much a reward system, which leads to like a really adversarial, dishonest relationship with your physician, where you're not going to be honest about things, and you're going to lead towards things like urine screen tampering, where you're going to do what you need to do to ensure that you can maintain your carries. Why? So that you can, you know, work. And that really goes against the whole ability for, if I can't be honest with my doctor, and my doctor's not willing to work with me because they're constrained by these rigid systems where, you know, the purpose of a carry is to allow somebody who has stable housing, who has a stable life, to be able to maintain a normal semblance of life. That's to say work. And then again, like, this is something that really simply could be set up with a simple phone call to say, hey, listen, I'm out of town and I'm stuck and I need to have my old prescription canceled. I need to have a couple carries arranged for out of town. But here's somebody. So and what has he done? He's gone out and he doesn't have a carry. So he's gone and he's picked up some fentanyl so that he's not in withdrawal. When he comes back, do we penalize this person? I would say no. If the person is stable and the person has had a history of stability, why impact somebody's life negatively when there's no impact to the public and to him? So
you make it sound very obvious and really question why we were operating under these other structures. I mean, I know that there are historic reasons for them, but I'm glad we're having this conversation. And I think that in some ways, the guidelines that we've proposed were really written sort of in like counterposition to the CPSO guidelines. It felt a little bit radical and going out on a limb maybe at the time. And now I have to say it feels like it's not probably far enough, you know, if we really start relooking at them from a patient-centered perspective, a client-centered perspective from the get-go. So again, happy to have feedback on that as we go forward. I think we've already explained really the background. We just felt that the recommendations to start and titrate doses conservatively were written in a different time when prescription pharmaceutical opioids were the primary opioids that we were seeing. And that these obstacles created many challenges for people to want to participate and engage in treatment. So this was really an ad hoc group working sort of under the auspices of Medify that came together. And I feel like I maybe missed a slide somewhere, or it's coming up and I've missed it, but we did a bunch of literature searches, and I think it's coming, tried to come to consensus around evidence where we could. and then agreement amongst ourselves, and then it was shared. But sorry, I think that slide may or may not be coming. So this is just, again, to highlight for people who kind of know, but maybe not so clearly, what it is that we're talking about in terms of fentanyl. So a point of fentanyl being 0.1 of a gram, so a gram is 10 points. And these approximate equivalencies come from various places, but including the documents and literature from the National Safer Supply community of practice that get us thinking that a point of fentanyl is about, somewhere between 32 and 48 milligrams of hydromorphone, which is about 200 milligrams of morphine, which really makes you recognize the inadequacy of our starting doses of methadone for people who are using a gram or 2 or 3. And this is a slide from Tally Cahill, who's a nurse in Ottawa working in SCS there, and her unpublished thesis. And it supports what I keep hearing anecdotally from our eMERGE colleagues about patients who come into the emergency department who are on methadone but have overdosed, and the majority of them are on less than 60 milligrams a day. So this is showing that if people coming into the SCS using opioids, the majority are on really low doses, 50 milligrams or less, compared to those not using opioids. So what are we missing in terms of, trying to sort of understand this difficulty around getting people who use opioids onto adequate doses of OAT? I'm not suggesting that everyone wants to be on high doses or that OAT is the be-all and end-all, but we're talking about, a spectrum of care that, from my perspective, really needs to be focused on engaging people so that we can reduce the harms. So this was the slide that I was talking about. We did our literature searches when we could and find evidence. We tried to really rely on that. We relied on our experiences and guidance. And then we shared the document in development with other clinicians working in different healthcare settings. We solicited reviews from the Medify listserv. And then we ran a focus group comprised of people with lived and living expertise and family members through the CCSA. Andrew participated in that group. I will acknowledge that people with lived experience were not part of the guideline development. I think that was a gap. But as I go through the guidelines, we'll share the feedback from the focus group. And I think, as I said, there's more work to be done there. So we really know that, fentanyl is now responsible for probably 90% or more of opioid-related overdose deaths. We know that OAT is protective against overdose, even in people who continue to use fentanyl. And there is some evidence that it's protective not only because people use less or use in less risky ways, but some animal studies that show that being on OAT helps to maintain respiratory tolerance. So that when people have periods of not using fentanyl or other opioids, and then they resume use, they've maintained that tolerance. And so that may be one of the mechanisms that makes them less likely to experience overdose. So we really came at this from the perspective that rather than being focused on a specific schedule, that we should, whenever possible, make clinical decisions that would help to support patients engaging and remaining in treatment. Again, that those doses of 30 milligrams and 30 to 50 or 60 keep people at high risk of treatment dropout and overdose. And that not to minimize the risks of prescribed methadone, but when prescribed carefully, the risks of methadone toxicity are substantially lower than the risk of overdose with street supply. And having said all that, we still need to be careful understanding the pharmacology of methadone, the bioaccumulation, especially in the first 2 weeks before enzymes are induced. So our goal was to create strategies to help reach an optimal dose of methadone safely and effectively. And that involves being more flexible and probably continuing to try to be more flexible even in these guidelines, as I've shared. So we recommended starting at a dose of 30 milligrams, even when the urine drug screen shows benzodiazepines, unless the patient demonstrated toxicity or was at really high risk of methadone or benzodiazepine toxicity, such as the elderly, people using lots of alcohol, or those with COPD. Why did we cap it at 30 milligrams and not higher? Obviously, the majority of guidelines recommend 30 milligrams as the highest dose. We actually subsequently found that the Quebec guideline recommends that you can use a maximum of 40 milligrams as a starting dose. And one of the ASAM guidelines does as well. What we felt was that those rare protocols that allowed for a dose of 40 milligrams then recommended smaller and less frequent dose increases and didn't end up at a higher dose at the end of a 2-week period. And so I think probably our own sort of comfort level with that 30 milligrams upper dose is what drove us thinking about methadone metabolism. And as I said, sort of the issues around enzyme induction. And the fact that even though, we keep talking about high tolerance, that cross tolerance to methadone is incomplete and variable. And Andrew, I'll let you speak to that before I talk about our sort of mitigation strategies.
It's this understanding that anything below a 30 milligram dose was simply not a realistic starting dose. And yes, starting somebody at a minimum dose of 30 milligrams is absolutely critical, but coming up with a strategy in which if somebody is, and there's two different sides of the coin. Somebody who's just walked in the door and is doing 2 to 3 to 5 to a half a gram of fentanyl on a daily basis, we want to get that person to a dose where they're absolutely able to be comfortable and not be out there seeking additional fentanyl or opiates so that they can be at a stable level. But the second key piece is, what about somebody who's been at 100 milligrams or 120 milligram dose and has fallen off as a result of X, Y, or Z, getting them back to that and starting them at 30, absolutely great increase. But then how quickly and safely can we get somebody back to a stable dose? I mean, a lot of this comes back, and I know we're going to speak to it later on, but what's the goal here? Is the individual looking to continue using, or is the individual looking to get to a dose and then try to stop using altogether? And that's something that, from a conversation that very few physicians that I encountered in my 20 years had with me. So the 30 milligrams makes a very insignificant impact on my withdrawal if I'm using a half a gram or a gram of fentanyl a day.
I hear you. Yeah. So our strategy was to suggest co-prescribing Cadian or slow-release oral morphine. This is the off-label portion of the talk. And the suggestion really comes from the 2008 Saskatchewan Methadone Guidelines, which are not their current version either. And there was no peer-reviewed published literature around this, but we had a number of conversations with Peter Butt and others who had been involved, who had no adverse outcomes co-prescribing 100 to 200 milligrams of SROM alongside methadone. And in fact, I think those guidelines advocated pre-planned dose increases too, up to 3 dose increases. So the reason that SROM can be used is because it does not have the same bioaccumulation. This isn't a talk about SROM, but basically, its long action has to do with the way the capsule is broken down initially in the stomach, and then the tiny beads are broken down in the higher pH of the intestine. And so, there would be concerns around someone who had short bowel or other kinds of issues, but for the majority of people, obviously a lot of caution needs to be used around those who have serious renal insufficiency. SROM can be used safely. It hits its peak later than methadone, so sort of 8 to 10 hours, and it achieves very stable levels overall. Just going through the rest of some of the guidelines around how to titrate, we recommended that methadone could be increased by 15 milligrams every 3 to 5 days. So again, not sort of playing around at the 5 to 10 milligram dose increases. Being cautious about those who are at high risk for toxicity, but again, assuming that for the majority of people, not one-off fentanyl users, not all prescription opioid users, but those using fentanyl in high-risk ways, really aiming to get that dose up rapidly but safely. So that would be 30, 45, 60, 75, and then considering going up by 10 or by 15 for another dose, and then 10 milligrams every 5 to 7 days for there. Again, we did not recommend slowing titration for people whose urine showed benzodiazepines, given the prevalence of benzodiazepines and benzo analogs in the street supply, unless people were, using benzos as whether street or prescription in high-risk ways or had other risks of toxicity. Of course, all of this has to be balanced by looking at the person who's sitting in front of you, having a conversation with them, observing for sedation, listening to their reports about how they're managing. And we recommended that STROM could be titrated along with methadone in increments of 50 to 100 milligrams. So again, trying to get that total pharmaceutical opioid dose up. We recognize that for most people, doses above 100 milligrams will be necessary, and sometimes quite a bit higher than 100 milligrams. There's a lot of literature going back to the pre-fentanyl era on higher doses and more flexible approaches to doses being more effective for people, both with respect to remaining in treatment and reducing their opioid use. All of these articles are in the reference section for those who want to look. But there are doses that you can see have gone up to many hundreds of milligrams. And a study by Stone et al., I think that's the Rhode Island group, who found that specifically in people using fentanyl, because there's not a lot of literature on methadone in people using fentanyl, that a median dose of 100 milligrams of methadone was more effective in helping people remain in treatment than those at lower doses, as well as with sustained remission. We also recognize that in the past, people were very hesitant to increase the methadone dose if there wasn't an ECG on board. Some people wouldn't even initiate methadone at all without an EKG. The literature is really not that strong in terms of suggesting that everyone should have a baseline ECG before starting treatment. And what we've suggested is that we really need to look at individual risk factors for cardiac arrhythmias in terms of underlying cardiac conditions or other QT prolonging medications. That EKGs are certainly warranted as people are getting to 150 milligrams or more, especially for people who have other risks of arrhythmias. If you can't get an EKG and someone is at 150 milligrams and needing some kind of extra dose increase, then you have to use your clinical judgment around whether to increase while documenting and continuing to request an EKG or add morphine instead. And Andrew, I'll turn it over to you to comment on some of those things.
Yeah, I remember being asked to go and get an EKG, and it took me about a year and a half to get it. And it was something really simple. I didn't have a health card, and I was absolutely incapable of managing my life. It's probably at one of my darkest points in the process. And I remember being at one clinic, and I was absolutely told, no, we're not even going to start you on the program until you get this. You need to go get a health card. You just can't go to get a health card. You don't have ID. A good number of patients that are there simply don't have ID. The clinic had my ID on file, and that absolutely impacted my ability to do that. Thankfully, I was linked up with another clinic who was absolutely willing to start me on the program and get me through to this point. I was looking at how the guidelines or the proposed guidelines to increase people faster is absolutely the desire. I found that for myself, sitting at a dose of 30 to 40 milligrams was more of an inconvenience then it was helpful. That's to say, having to go into a clinic, into a pharmacy on a daily basis, not being at a level that's going to absolutely do anything for my mitigating my withdrawal, but is absolutely impacting my ability to work a job, to live any semblance of normal life. And it wasn't until I was somewhere between 85 and 120 that I found that I was able to not be sitting in constant withdrawal throughout the day. So yeah, I hope that's helpful.
That's super helpful. So one of the key things, key challenges for people that you've alluded to is missing doses. And we know that early stabilization is a risky period for MMT in terms of overdose, but it's also arguably the most important in terms of engagement in therapy and getting someone started to get towards that effective dose. So we recommended that rather than canceling doses after day 3, adding on another day. That if someone had missed 4 days and then presented on day 5, that we would use the previous approach of reducing the dose to 50% or 30 milligrams, whichever was higher, and then increasing 10 milligrams a day for 3 days. So we just sort of moved everything from the CPSO guideline out an extra day. I have to say, just this week, I faced a dilemma where a patient who was on 170 milligrams missed 5 days for various reasons. And I looked at this slide and I looked at our document and I thought, like, starting someone on 30 milligrams from 170 who's been using just feels like such a drop in the bucket. So, I think some of you have asked, I'm looking quickly at the chat, how do we do this? What's the common understanding? What about risks? What about the college and the CMPA? I think we're continuing to learn, but I think, in that kind of situation, where we know that someone has lost some of their methadone tolerance, but is using fentanyl and continuing to maintain their opioid tolerance, restarting them at 30 milligrams, even with 100 milligrams of Cadian, to me, feels really inadequate. And we may be able to come back to talking more about that. But the other situation that's so challenging when people miss doses is what to do about dose increases. And I'm sure as prescribers, we've all faced that situation where, someone has gotten themselves, or we have worked with them, they've been taking 60 milligrams, and the plan was that they're coming in on a Thursday, having had 3 doses, to increase their dose again, and they missed the day before. So all of a sudden, they had 2 doses and not 3, and you're going to be stuck, right? So we really felt that it was important in people who are very challenged at getting those doses to have a little bit more leeway, and that they don't necessarily need to have 3 consecutive doses. They could have 4 non-consecutive doses. So if you saw them on Thursday and they had Sunday, Monday, missed Tuesday, had Wednesday, that you don't need to wait for another 2 days of consecutive doses before increasing that dose. This is spelled out a little bit more in the document itself. This isn't for everybody. This isn't for people who are at, really high doses already. This is a strategy intended to help people get up to at least 60 milligrams. And certainly, I think many of us have found that once people get to 60 milligrams, they then are, I think, a bit more likely to continue to attend and to be able to, manage the appointments and the doses all a little bit more effectively. We don't suggest increasing the dose if someone has actually missed the day immediately before. We would suggest continuing that dose for another day and then increasing planning. So you don't have to see them again. You can say today's dose is 45 milligrams. Again, this will be the 4th of the 5, and then tomorrow's dose can go up to 60 without another assessment. Andrew, you want to comment on that?
Yeah, so and I love hearing that this is the goal that we're going towards, as opposed to, and back in the day, I'm trying desperately to get back to a level that's going to allow me to be able to not, live at home in the shower in bed sick as a dog. And, I miss 1 dose because I've been so sick and I've slept through the pharmacy. But I've gotten every other dose up until that point. But no, I'm sorry, you've missed one of your last 3 consecutive doses. So here's the kicker is that, and Andrew, yeah, so your doctor's not in on Tuesday. So we'll see you a week from Tuesday. Mm-hmm. At which point I'm like, a 24-hour period for somebody living in withdrawal is agonizing, but 7-8 days until I can see my doctor next. Or maybe you can come in and sit as a walk-in at the clinic for 9 hours and hopefully see somebody who's going to be really, doesn't have any history of me and is going to be even more reluctant to increase my dose. So seeing that there's some additional flexibility is absolutely wonderful.
So I think, Andrew, maybe you can speak to some of the items on this next slide, which, as we've said, are really beyond just the dose. What are some of the other things that can help to make treatment, care, an OAT clinic or setting or approach, more appealing for people who would benefit?
Yeah, absolutely. And I was reflecting on this earlier this week. I came into this program when I had difficulty with Percocet and Oxy. And what ensued over the next 20 years was a very ineffective relationship in a lot of ways with my physician. And I don't blame this on the physician. I blame this on a system that was rigid and that really didn't focus on patient-centered care. You know, what's the? Did I have a conversation with my physician where they said, you know, what's your goal here? Are you interested in stopping the use of opiates? What's your goal in terms of coming off or staying on or stabilizing on methadone or cocaine or whatever the case might be? I mean, for a good number of years, and I remember I went a period of time where I wasn't using any oxy, any opiates, but yet wasn't eligible for things like take-home doses because I used cocaine. You know, at no point were the carries that were there something that was provided based around stability, but rather based around having a clean urine screen. You know, in all honesty, I didn't have a whole lot of clean urine screens during the time that I was on methadone. But I always had this fear that if I told my doctor that I was using, that I was going to be treated differently. And that lack of honesty absolutely impacted my doctor's ability to be able to help me. You know, quite often, you know, and I remember the old analogy of how can you tell when somebody who suffers from substance use disorder, or how can you tell when an addict is lying? Well, because their lips are moving. And I was very seldom honest with my physician in regards to what was going on with me. And that absolutely impacted their ability. So I think a lot of this comes down to taking some time when a patient first comes in. What's going on in life? What's your goal here?
So I think I'm going to skip ahead because I'd like us to be able to take questions. So I'm having trouble moving the slides ahead. To really talking about take-home doses and what we've learned from the pandemic, and then being able to open to some questions. So I think, you know, many of you contributed to and helped with dissemination using the Ontario COVID-19 OAT guidelines that recommended a number of changes to support public health recommendations, allowing people to isolate, both those who were sick and those who were trying to protect themselves, and maintain continuity of care. And under these guidelines, it was recommended that, you know, people who previously had carries could move up in terms of the number of carries quite quickly. People who had 5 or 6 carries could get 13 or 27, and that people who had no carries previously could be considered for up to 3 non-consecutive carries per week, as long as they were not super high risk. So not suitable meant they were intoxicated or sedated when assessed. They were really acutely unstable in terms of psychiatric comorbidity. They had just recently overdosed. You know, Andrew, we sort of use that word stability, and I'm aware of I guess the biases that can come with using that word as well. So there have now been a couple of studies looking at that. One was a survey led by Kim Karan that I was involved in with funding from CCSA. And this surveyed methadone prescribers as well as people on methadone. It also included people on buprenorphine, but I'm just focusing on the methadone. 74% reported that changes OAT helped them to be more open with their prescriber. We talked a little bit about honesty and lack of honesty. Also, I want to say that on the survey, people reported that those who received additional carries did have an increased likelihood of sharing their carries or trading their carries for food or other goods. But what was so striking to me was the number of people who did not receive an increased number of carries. So those who were already receiving carries, who under an anonymous survey acknowledged sharing or trading carries. So I know that's quite scary to some of us as prescribers. I think it's important to recognize that there are many different reasons that this could be happening in terms of trying to help friends or family members who don't have access to care, lack of access to food, housing, or other kinds of supplies. But there was no increased risk of overdoses or emerge-related visits for people who received, or hospitalizations for people who received increased carries. And this is the article in JAMA. The link was at the beginning of the presentation, using ICES data. So this is like pretty hardcore, using ICES data to look at the number of doses and carries dispensed relative to all kinds of hospital data for emergency department visits, opioid-related overdoses, treatment interruption and discontinuation. And what this showed us was that in people who previously did not receive carries, that's the top section, so those who had been getting their methadone daily, that receiving take-home doses was associated with lower risks of opioid overdose, lower risks of discontinuation and interruption of therapy overall. And the increased all-cause mortality and opioid-related deaths were non-significant. So I think most of us would have felt comfortable and thought that, you know, we would see those impacts on people in the lower half of the grade, those of the table, those already receiving 5 to 6 carries per week. But really significant that we saw that in people who had not previously met criteria for carries at all, but received carries under the pandemic guidelines. Now, the data also shows us that a majority of prescribing patterns reverted by November 2020 back to pre-pandemic approaches. So there's a small group of prescribers who are still applying the sort of pandemic carry approach, or what we might call sort of a more flexible approach. And I think, you know, really what we need to look at going forward, and this is another Medify project, is to look at how can we approach carries going forward as part of our overall approach to OAT care, looking at patient stability, and looking at the benefits versus risks of carries overall. So just to try to wrap up and leave some time for questions, again, I think, you know, we really recommend using strategies to try to reach optimal doses of methadone. Optimal is individual, but it's a lot higher than it was when we were practicing 5 or 10 or 15 years ago. That doesn't mean that we throw all caution to the wind in terms of starting doses or dose increases, but that we really need to consider how to take a much more flexible, patient-centered approach overall, and then think about what else it is that we're providing, right? How can we really think about care being not just about a methadone prescription and that transaction, but what else is going on within the relationship, the care for you know, medical illnesses, mental health conditions, looking at all of the other social issues that are there, and truly think about OAT as part of that spectrum of harm reduction, person-centered, and trauma-informed care. So sorry for not leaving quite 10 minutes for questions. I think lots of them are probably for Andrew, but Karan, can we just lean on you?
Sure, yeah. Thank you so much, Jennifer and Andrew. That was an excellent presentation. Just in interest of time, I'll get started with the questions. So somebody asked, how would you know if patient is being honest about use versus stating higher amount of fentanyl to get a larger starting dose?
So how can you tell? Well, aside from obvious, and I mean, this can happen through a conversation. I recall sitting with my doctor having a conversation which started with, you know, your urine screen is positive, Andrew. You know, how many times did you use this week? Which I used, my blanket answer was, oh, that was 4 days ago. Truthfully, I think it had been that morning. And I fell asleep in the office with my doctor there. So using your own common sense judgment based on viewing somebody, but a lot of this comes back to learning to have an honest relationship with your patient and say, listen, I want you to understand that it's okay for you to tell me if you've used and when you've used, because our goal here is to try to get you. And what is the goal here? Do you want to become abstinent from using? How can I best support you through harm reduction, through potential links to or referrals through to treatment? You know, if somebody's looking to get sober, or is somebody looking to get stable on methadone and continue using, and being okay with that. I mean, what we're trying to do is prevent death and trying to promote stability within people's lives. And when we foster this honest relationship between my physician and me, that all of a sudden honesty is a lot easier. when I'm not feeling this risk of judgment or this risk of concern. How can you tell? Well, there's all sorts of, you can urine screen somebody, but it's just as, there's so many people work their way around that as well. I mean, honestly, I'll let you go ahead there, Jennifer.
Well, I think there's so many different aspects to that question. I think you highlighted the fact why people are not honest, and that the goal is to create a relationship where there can be. Obviously, when you don't know someone, you don't have that as a baseline. I guess people may be looking for a higher dose, but I would say, what's wrong with that? If a higher dose of methadone is going to help someone reduce their use of street fentanyl, which is so toxic, then I'm in favor of giving them a higher dose as a starting point to ongoing conversations around what are their goals? How are they using? Doing a follow-up, how are you feeling with it? Is it making you feel sedated or dozy and out of it? Maybe that's actually too much overall. And then I know one of the things that a lot of us have struggled with, even though we say that we're not, expecting or requiring people to be abstinent, is this notion about, using doses to get high, right? And, we keep saying we don't want people to feel, intoxicated or euphoric. That's not the goal. Just like we said for so long, it's not to treat pain, it's just to treat withdrawal. And the reality is that the lines are so much more blurred than that. And again, I think if we think about, harm reduction, I struggle a little bit still with some aspects, but, if someone gets a high from their methadone, a little bit or more than a little bit, but they're reducing their more risky use. They're coming back. I'm protecting them from some of the other toxic exposures. I don't know that that's the worst thing. I think that would be my answer overall.
Yeah, I agree. Thank you. And this goes in with the point Jillian shared that around the dose equivalencies between fentanyl and different regulated opioids, and also how much wide variability there is in composition of fentanyl from street supply. She shared that average of dose tested by Toronto Drug Checking is 4% fentanyl, but we tested one this week that was 77% fentanyl. So it's a wide range of variability. Leah asked if that she has people that she hasn't seen or spoken to for months. They are seen by pharmacists when they go in. I continue to send the prescription, and she asked if others agree.
I can say that I feel very comfortable leaving a prescription for 30 milligrams of methadone for people that I'm not seeing. I think, in the guideline, we suggested that if someone had missed up to a week of care for people who, struggle to sort of stay retained, just leaving a prescription at the pharmacy. And we had a conversation about how long could you do that? Could you leave a 30-day prescription? Like, at what point would you want to know how someone is doing and have some kind of interaction? So I really like that idea. I think it needs, as a lot of these steps do, communication with a pharmacist, because most pharmacies will cancel a prescription if someone hasn't been there in 3 days. So if you don't want the prescription to be canceled after day 3 or day 4 or after day 14, then you have to work with the pharmacy and make sure that they really understand where this prescribing is coming from. I had the same situation around dose increases where, let's say I had planned a dose increase for the day after a visit, and then the person missed, the day before, or missed that day, missed the day that the planned dose increase. And so the pharmacy just canceled prescriptions, right? So that's not good for anyone. And I think there's so much that we can do to try to improve communication with the pharmacy, and pharmacy to us in terms of being accessible to help come up with solutions for those kinds of situations.
Sounds good. And thanks, Leah. She added to clarify they're dosing regularly at the pharmacy. It's just if she can't reach them because they don't have phone or regular housing.
Yeah, and that makes so much sense, right? Why would you just stop care because someone doesn't have a phone or stable housing, right? Hopefully one day they're going to come in and then they're going to be able to get their dose increased if that's what they want.
Absolutely. RJ asked, what is the status of guidelines and methadone CPSO assessments now that they don't specifically exist? It used to be a bit of witch hunt for us prescribing MDs who tried to use common sense. How does CMPA feel about this tide change?
Again, I think there are lots of different angles to that. So I think that physicians prescribing methadone will now continue to be assessed under the regular sort of CPSO QI/QA process. I think that not only were the CPSO guidelines rescinded, but the CPSO, I think, effectively endorsed other approaches to treating opioid use and risks, including safe supply prescribing. So I think, as prescribers, when we look at a community of practice, and that's how we're sort of judged against community standards, I don't have any issues. I don't think defending this type of practice or explaining it relative to the risks in the community and relative to the standards that are being used and the quantities of opioids that are being used as part of safe supply. There's a statement on the CPSO website that addresses that, I think.
Okay, thanks. Mary asked, she's wondering if the guidelines and courses will be updated to support the new evidence from Medify and what we have learned from COVID and removing prescribing restrictions.
So part of the challenge is that there is no one body that's creating guidelines anymore across the country. My understanding, and there may be others on this sort of in the audience who want to speak to this, is that the colleges of physicians chose to step out of the level of regulation that was happening previously. There is a new document that is the synthesis of guidelines that CAMH helped to collate, which is really great, and it has to do with principles of care. And I would encourage people to look at that. There is a CAMH document that is in development around looking at opioid agonist treatment guidelines going forward. But there is no one guideline, and there will not be a guideline going forward that replaces or carries the weight of the CPSO guidance going forward.
Yeah. RJ asked a clarifying question. I think you mentioned regarding the dose increase, as long as they have had 4 out of past 5 doses, and he is asking, he thought it was 2 out of 3 or 3 out of 5 recent doses to allow for dose increase.
I'm looking at the document that I wrote because you got me thinking about it. And it does say that we recommend consideration of dose increases for patients who repeatedly face challenges, achieving 3 consecutive for people who have had at least 4 doses within 5 days, but they could be non-consecutive and not the day prior to the dose increase. Having said all of that, this is our version and approach. I have to acknowledge again that there is not strong evidence to support this, but we're looking at, tolerance and loss of tolerance issues, and again, risks versus harms. So, it's certainly feasible to consider, different approaches.
Absolutely. Will they have access to these slides? I know the recording will go up online in next few weeks for sure.
I believe so. And if anyone would like them sooner, feel free to email me.
Thank you. And since it's 11:25, I just want to be mindful of the time. I'm sorry if any of the questions weren't addressed. Thank you so much again, Jennifer and Andrew. This was an excellent presentation. And these guidelines certainly have really helped me kind of adjust my practice to the current climate. And I can speak on behalf of the patients I see in my practice that having the SROM added with methadone, especially in the beginning, they find it very beneficial. And I have found it really helps with the retention until they get to a therapeutic dose of methadone. And thank you again.
Thanks so much, everyone.
Thanks very much, everybody. I appreciate your time.